Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. As you know, in 2020, many states, countries, and in some ways the entire globe went into a lockdown from the coronavirus pandemic. And with that, many professionals, practitioners, and people living with pain were introduced for the first time to telemedicine and telerehabilitation. So I wanted to explore some of the research and the applications with you this week and invite a special guest on who can help us talk about some of those topics. Joining us this week is physiotherapist and researcher Bruno Saragiotto. Bruno is an assistant professor at the City University of Sao Paulo in Brazil. He's also research affiliate at University of Sydney and co-leader of the Center for Pain, Health, and Lifestyle. Bruno has published over 70 research articles that focus on telehealth, healthcare innovation, and access to technology. On today's episode, we discuss how you can use telerehabilitation to treat those with chronic pain, as well as how you can use it as an effective tool for the promotion of physical activity. Okay, without further ado, let's begin and let's meet Bruno. Bruno, welcome to this week's episode of the Healing Pain Podcast. It's great to have you here.
Thanks, Joe. It's really a pleasure.
I'm excited to talk to you about exercise and the promotion of physical activity as it relates to the alleviation of pain, especially with regards to telerehabilitation, which has been important all throughout this year with COVID. And I think it's going to continue to be important as we move through COVID and move out of COVID. Recently, you published a paper in the Journal of Orthopedic and Sports Physical Therapy called The Effectiveness of Strategies to Promote Walking in People with Musculoskeletal Disorders. It was a systematic review and meta-analysis. Everyone can, of course, access that in the October edition of the Journal of Orthopedic and Sports Physical Therapy. But to get started, tell us what the aim of that paper was and why you decided to do this research.
Yeah, sure. So this paper, we looked at promotion of walking. And when I say promotion, I really mean just the promotion of walking, not supervised walking activities or any supervised exercise. So we looked at promotion of walking for people with several chronic pain conditions, which included back pain, neck pain, osteoarthritis, and rheumatoid arthritis. So the idea of the paper came from something that I really like, which is simple interventions that is scalable to public health. So promotion of walking, of course, is the case. So we compare promotion of walking with minimal or no treatments, usual care, and supervised exercise. And we investigated some outcomes such as physical activity level, pain, and function. And do you want me to describe the results? I can go through everything. So we found that strategies to promote walking, they do not increase physical activity level, but they improve with small benefits for pain and function, even when compared with supervised exercise. So I think this is very interesting results because we didn't expect that. So we expect that would increase levels of activity and maybe will have some effect on pain and disability. But I think was an interesting study to conduct.
And in that study, so you mentioned strategies to promote walking in people with musculoskeletal pain disorders. What type of strategies are included in that paper so the listeners have an idea of the type of interventions that you reviewed?
Yeah, it's very mixed up. We have 12 studies, including this study. And we have just studies with motivational interviews by a health practitioner, like telephone calls, like a coaching. We have coaching for 1 year coaching, just still around the motivation issues. We have just instructions for walking. We have some studies with pedometer, and they have like a target, a daily target, and education booklets. And I think we have 1 or 2 studies that use a website, was more in the format of telehealth. And
Excellent. So for
just
example,
complementing the comparisons were pretty much education, no treatment, waiting list, or any other supervised exercise.
right. So a wide range of strategies. So motivational interview techniques, telephone counseling, in-person coaching, just general instruction, using a pedometer, which you can help track, obviously, steps in physical activity, an exercise booklet or an education booklet, and then a website. So lots of different types of strategies. And they all seem to have some kind of effect, it sounds like.
Yeah. Again, they did not significantly improve physical activity levels, but what's interesting to find small effects for pain and function. And we didn't have any cutoff for clinical meaningful results, because we let it open on purpose, because very small benefits could be interesting for public health interventions.
So how, if a physical therapist is reading this paper and they're seeing all these different types of strategies, and they're entering into an environment like we've been in the past, 8 months with regard to telerehab, which one should they choose? Should they feel confident that they can choose any of those? Is there something about the paper that points us in that direction with regard to helping a clinician decide, okay, I have someone who's interested in starting a walking program. How do I effectively counsel and help them with the behavior change needed?
Well, I'm not a psychologist or someone who really studies in deep behavior, but I know that information usually doesn't change behavior. We need more than that. And especially when we talk about people with pain, because we have a lot of evidence showing that the same strategies for promoting walking, they improve steps per day and physical activity levels in the general population. But when we talk about people with especially chronic pain, I think the scenario is a little bit different. And maybe we need to focus more on the pain context and get into account the pain experience in general. So maybe one explanation, because people with chronic pain, they don't improve the physical activity levels in the paper, is that these campaigns usually they doesn't take into account, for example, the fear of movement that these people will develop. So it's something that we know happens with the pain experience, and we need to take into account the context as well. So I think something that clinicians can take from the paper is that you need strategies of education, but especially you need to show the patient that they can do it. They are able to. And after, I think they will feel, we don't know the right answer right now. I don't think we have, but I think accounting for the specific things on pain, I think is a way to go.
And if there is a patient or a person interested in exercising, but walking wasn't necessarily what was interesting for them, that's not the particular activity they wanted to begin with, is there a particular type of exercise that benefits people with chronic pain?
Well, the short answer is no. I studied a few different types of exercise in my PhD, and we know that we have a lot of types of exercise. We have some focus on trunk stabilization, some on strength, flexibility, or general exercise, aerobic exercise. But I think the good news for me is really good news, because all evidence that we have so far shows that there's no difference between those types of exercise. They seem to be all effective at some level. So this is good, because for the patient point of view, they don't need to spend more money for a specific exercise. For example, Pilates exercise, yoga, if they don't want to do it. So it's because usually it's more costly. And if they like in sports, they like to swim, they will probably get some benefit of it. And even for the clinicians, I think this is a good point, because they may not need a very specialized training, which is also costly. And sometimes a clinician just doesn't like a type of exercise, or they have a previous training on motor control exercise. So I think they should use that. And for public health, it's great as well, because simple strategies can work. So it's a win-win-win situation. I think we just have the challenge to get people doing more regularly and engaging in strategies.
That's right. That win-win is what we want, to help engage people with any type of physical activity when they're living with pain. If someone decides that walking is their method of choice for exercise and physical activity, how does walking help with chronic pain? How do we explain to people and describe to people how walking helps with pain?
Well, we actually don't know that answer. We don't know much about mechanism. It's, for me, it's, I think, one of the areas in science that we need more development, especially to explain people with pain. We don't really know that. We don't really know exactly how that should work. In your study, we have a hypothesis that is not for a biological point of view. It's more about having the social component and having an activity that is easy and very easy to engage. So this may be the way that people feel they will get better. And that's why maybe they improve it a little bit on pain and function. Mm-hmm. Maybe because all of the interventions included in the review, they had a social component. So I think we decided to discuss more on this external point of view instead of going into the biology, because we actually don't really know. We have a few guesses, but we are not sure.
So you mentioned two. So the first was something that's easy for someone to engage in. So for example, walking is relatively easy. All you need is a pair of shoes and some loose clothing, and you can do that outside of your home in most neighborhoods, so to speak. And then a social component to it. So either an activity that's socially acceptable or socially engaging to someone, or where there's friends and family and other people that are meaningful to you that you can engage in the activity with. Yeah. Are there any other components that were important with regard to how exercise may help people or be effective with regard to pain?
Well, I think, for walking, it's also good when you start walking. Maybe some people would like to start running or start going to the gym or engage in other activities. So I think this is interesting because it's a first activity for someone who is very sedentary. So they just start walking and then they start liking. They see that it's easy. They can see some people running and they try to run and they starting a running program. And then I think it's a good way to healthy behaviors.
Yeah. So taking that activity that's easy for people, and then once they feel that reward system in their brain start to kick in, learning to use that activity in other life environments and other life contexts, and then helping them with that exercise progression to things that are more challenging and physically demanding for them.
Yeah, I agree. And I think we have some strategies to help people. Like we have some studies that use a pedometer, so it's a good feedback for people to see their progress. We have lots of technology helping on this monitoring world. Mm-hmm. So, very simple device as well.
Yeah. So technology could play a role and help people with, for example, walking. Because you mentioned in your study you looked up pedometer tracking.
Yeah. We have some on pedometer included.
Excellent. So bring us up to date and tell us about your current research and the implications with regard to telerehabilitation, and probably for you within the Brazilian health system, which may have some parallels to the US health system and some of the things we're experiencing.
Yeah, I think so. So at the moment I like to study, as I said at the beginning, I like simple interventions that is scalable to public health. And at the moment, I'm conducting a lot of studies in telerehabilitation and ways to improve access to technology. We are currently in our research team. We are leading 3 Cochrane reviews on mostly testing the effectiveness of telerehabilitation for people with back, neck pain, and osteoarthritis. And we also have our main study is a clinical trial on telerehabilitation. We designed a telerehabilitation platform using some of the implementation steps of going to the clinicians, ask them which exercise would work better remotely, going to psychologists and patients, asking them which information they want to they prefer. And then we are testing this trial. We are in half of the recruitment right now, so maybe still another year we'll have some results. And we also have a few studies on how people access internet to get information, some qualitative studies, and why do they search for help on the internet, and some studies on health literacy, which is a core for all internet interventions. And you asked me about how this fits into the Brazilian health system. So, well, in Brazil, I think, as you may know, because you have few Brazilians here, we have this unique health system where every citizen has free health services. So it's a beautiful model, but has some practical problems. And one of them is long waiting lists for diagnosis and treatments. So, and also telehealth is not a reality right now. We have data from I was getting some data from the public system, and we analyzed 5 million people that use telehealth in the public system between, I think, 2015 or 16 from today. And we found a very weird trend, because during the COVID pandemic, the number of telehealth consultations have dropped. And we find that most of the care were specialized health service, like dermatology, orthopedics, and not like family physician or someone in the first contact or primary care. So the right telehealth model would fit in the public system in Brazil very well if they can optimizing waiting lists, perhaps with prediction models, with triage, or even for simple treatments. I think wouldn't solve all the problems, but I think it's part of the solution, definitely. Yeah.
And the telehealth system that you're working on and developed, it's video conferencing with a licensed physical therapist or a licensed practitioner?
Yeah, it's mixed. We have a coaching with a physical therapist. We have which perform some live sessions, but most of the program it's in the website, where the patient can have the program coming every week. So week 1, they'll have access to a PDF with some exercise, the videos of the exercise, some very short animated videos for pain education. Mm-hmm. They have linked to blogs, some reading materials. So they have, like, every week they have a new package. And then you have the coaching controlling this, because the coaching can tailor the intervention. So if a patient starts feeling some pain or developed some fear of movement, so the coaching can actually tweak the progress a little bit, change the exercise. So it's a total of 8-week program. And we think would fit very well in the public health system, because we designed for that. That's why we have more asynchronous than live interactions. Yeah.
That's right. Asynchronous is the important word, I think, as you said there. People can access it and they can download it and play it and read it on their own time and go through it at their own pace. You mentioned coaching. Is that coaching provided by a physical therapist, or it's a health coach? Physical
therapist. Yeah. He did some training, online training on health coaching, but it's pretty much basic, because we need a physical therapist, because we need to change exercise. Right. And he's a physical therapist with some specialization in behavior and pain education. So it's good, because he can reinforce some of the animated videos, because we have very short videos with one topic. Like today, I'll explain what is pain. So it's like 2 minutes explaining this, 1.5 minutes. And then he can, during the coaching sessions, he can, to talk a little bit more about it, and if they have questions, they can answer.
Right. So a little bit of pain education that's mixed in with the promotion of exercise and physical activity as part of that platform, and then it's asynchronous over 8 weeks. I think that's a really nice framework for lots of different diagnoses, and probably, I'm just thinking with regard to the U.S. system, 8 weeks is probably the average time that we see someone in clinical practice. Brazil is a big country. Lots of people, lots of square kilometers. What are the barriers for something like telehealth in the country of Brazil and potentially maybe telerehabilitation across the globe?
Yeah, sure. Well, thinking on a world level, I think the most known barriers are maybe the impersonality, privacy concerns, technical problems, digital health literacy, like low tech ability. For Brazil, and I think this is the reality for all low and mid income countries, the way I feel, and the studies we are conducting are showing that the main barrier is access. So Brazil is the country with more internet access in Latin America, but still more than 1/3 of our population has limited or no internet access at all. While in the US, I know that I think more than 90% of the population are connected. So I think that's the main barrier. During the pandemic, we have an interesting example. The government launched like an emergency fund is for people with low income. And all they had to do was to download an app and follow very simple steps. Simple for me, that I have PhD, I work with that. I have some tech ability. But what we saw is that the next day or the next week of they launch these emergency funds, all the agents of the national bank were full of people that couldn't follow those instructions. So or couldn't access internet. So we have the problem with access and the problem with digital health literacy, which brings us back to education, basic education.
Interesting. So we have the technology. It's just a matter of making sure we can deliver it to everyone. And I think that the part of what you're saying is the simplicity of it, because technology in and of itself is complex. But us as practitioners and clinicians and researchers figuring out how can we deliver this in a way that's simple for the varying different types of patient populations that we see and their own literacy with regard to accessing and using technology and then understanding what we're delivering to them. That's interesting to me.
Yeah, I think there's lots of initiatives on using just social media or like the WhatsApp app that is just messaging. And I think they can have interesting results. Yeah. Simple things. Yeah.
So that's interesting. So using the WhatsApp, it's called, right? The messaging.
WhatsApp. Yeah.
Is that a good way to help facilitate and move these telerehabilitation initiatives forward?
Yeah. Well, at least in Brazil, we have we're doing some studies with low-income population. And what we found is that they have limited internet access and they don't have much memory in their cell phones. So, but WhatsApp, the WhatsApp app, they will have, because everyone has in Brazil. So they have this. So if you design an intervention that you don't need to download an app, or you can interact through WhatsApp, which is something in the context of Brazil is what people use. And you can send videos, you can send photos, a PDF you can send, and you can even call, making video calls. So I think you can deliver that using what people use. So I think that's key.
In the study you're designing, it's delivered. Is the content delivered via email, or they have to log into a platform to access the content?
They have to log into a platform.
Right.
It's a website responsive to the phone, and they have to log in because the login is where they have the randomization process of the trial. So we couldn't skip the login. Otherwise, we have too much work to do. But it's a very simple website designed by an agency, and they actually choose the colors and everything to the context of Brazilian people.
How do you think telerehabilitation and many of the things that we're talking about, how do you think it'll change the way physical therapists function or physiotherapists function in healthcare as we move forward with technology?
Yeah. Well, when I came back to Brazil after doing my PhD in Sydney, it was 2017, 18. In Brazil wasn't a reality. We didn't have any regulation. So I started doing some lectures where I was just telling people that telehealth, telerehabilitation is something that we don't have to be afraid. Something that is not will take your jobs away. So and that was purely the aim of the lecture. And then we have the pandemic, and then we have this emergency regulation of telehealth, telerehabilitation, and then everyone started doing it, but they didn't know how to do it, because of course, if you are a good physio, you have the knowledge. Mm-hmm. But when you're in a different environment, you need more than that. You need better communication. You need more creativity. You need to think about things that you normally don't think when it's a face-to-face consultation, such as, for example, in an emergency. It's good that you have the phone number, you have the number of another a relative to the patient, or the address if you need to send an ambulance to the address. So few things that we need to maybe we need another training for telehealth. Maybe we need a discipline at the physiotherapy graduation, because we don't have here in Brazil. We don't talk about it. We don't even have one about pain education. So we need one about technology. And the way I think it will change is because every profession, every health profession, they need to know a little bit about data science, about how to manage data and how to interact with technology. We don't need to start coding, programming, but I think we need to understand more about how data is gathered, because the patient, maybe in 20 years, the patient will arrive with 1 tera of data in his smartphone. So we need to interact with it. I see a nice future, but I think we need to develop maybe communication, creativity, or sense of collaboration. And I don't think we'll lose our jobs.
I mean, do you see this moving in the direction where some populations may just have a asynchronous interaction, meaning they, like you said, they log into a platform or download an app and everything is there for them? Or do you see that eventually it'll be kind of like a hybrid where there is one-on-one in-person care, as well as the use of technology somewhere throughout that plan of care and course of treatment that helps with the behavior change, that helps optimize outcomes, that helps with the carryover that's required when someone leaves the clinic and goes home and goes back to work or goes into their environment, and the therapist isn't with them to supervise what's happening?
Yeah, well, I think the hybrid model is the best. It's just my opinion. But about the whole telehealth, I really like the idea of patient empowerment. So in a perfect telehealth world, a patient can have a diagnosis or even a self-management plan whenever they want, just using her smartphone. So if you have back pain and this back pain is enough to bring you to a consultation, you do at the same time. So you don't need to schedule, wait weeks. Sometimes in the public system in Brazil, you wait for months to get a consultation. And sometimes we know that for chronic pain, sometimes you don't need imaging, you don't need scans. And in a perfect world, I see a patient having the power and going to a prediction model at 3 years just to see for red flags or their prognosis. And then they have a self-management plan. And then they can start the hybrid model, going to some face-to-face consultations or even live interactions with a physician or a physio. And I think it's good. I like this. I think this is the thing that I most like in telehealth, because remove some of this, this medical paternalism that we have since Hippocrates, I think, 1,000 years ago, where the law was that the physician will give the order, or the health professional, the physios, will give you an order and the patient just obey. So for me, that's the beauty in telehealth. The patient having control and developing self-efficacy. And we know that for chronic pain, that's the way to go.
Yeah. Because the education part and the carry through behavior change is one of the most important parts, which telehealth can help support us through that. With regard to research and pain research, What's missing from telerehabilitation when you look at the literature? I mean, obviously you're working on 3 systematic reviews, but this is completely new. So for researchers listening to this, what are some areas that we just have no idea about this condition or how telerehabilitation can be effective for X, Y, or Z?
Yeah, well, we have a lot of research on effectiveness, either comparing with face-to-face or usual care or minimal interventions. We have a lot. We don't have much cost effectiveness studies, although it seems intuitive to think that this is maybe cost effective. We actually don't know. We are doing cost analysis in our study, but we are still far from our results. So I think cost is an area, and also acceptability and implementation. We don't know much about how this can be implemented, especially low and mid-income countries. For example, in this review that we talked about, or even the Cochrane reviews we are conducting, I think 90% of the studies comes from US, Australia, Norway, Switzerland. None are from low and mid-income countries. So that's a barrier that we have. Because Brazil is funny, because Brazil we have such a diverse social economical, because we have some just neighborhoods that you can have people who reflects for external validity, people in Switzerland, and people who reflect people in Bangladesh. So Brazil is so wide. But I think we need to look more at the context. So we need to more research on costs and more research on context specific and for low mid-income countries.
Bruno, it's been great talking to you today. We're definitely going to follow your work with regard to using telehealth, because it's such an important topic right now in pain care and physical therapy and physiotherapy. But tell everyone how they can learn more about you and how they can follow your great work.
Yeah, sure. I'm on social media. So Twitter is @bsaragiotto. So just copy the name you see somewhere here. And I also have a blog for early career researchers, which is called The Ice Cream Blog. It's not about ice cream, it's about the research. And I'm also on Facebook. You can find my name there. And here in Brazil, I'm from the University Cidade de São Paulo, so which is what the name means, City of São Paulo. So yeah. I'm based in São Paulo doing some research here. And we have a collaboration which is called In Health. So it's a collaboration between Brazil, Australia, Canada, and the UK. So and we are soon we'll have some accounts on social media and on website.
Excellent. So all those links, of course, will be included on the website at the Integrative Pain Science Institute, where you can review all the links that Bruno just mentioned. And of course, at the end of every podcast, I ask you to make sure to share this with your friends and family on social media, which includes Facebook, LinkedIn, Twitter, or a Facebook group where people are talking about telerehabilitation for the treatment of chronic pain and physical therapy. I want to thank Bruno for joining us this week. I'm Dr. Joe Tatta. Stay tuned. We'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.